Hey everybody, this is NUR105, chapter 37, diabetes. Diabetes is a group of diseases in which there is a disturbance in metabolism and the use of glucose that is secondary to a malfunction of the beta cells of the pancreas. So there's some different types of diabetes, right? There is juvenile, which is type 1. It used to be known as insulin-dependent diabetes mellitus, or IDDM. That one accounts for 5 to 10% of all cases. Type 1 diabetes occurs when the body's immune system destroys insulin-producing beta cells. There's no way to prevent it. People who have type 1 diabetes require injections of insulin to maintain life because they produce little or none of their own. In general, people with type 1 diabetes are more prone to serious complications like ketosis associated with an excess production of ketone bodies leading to ketoacidosis or metabolic acidosis. Moreover, type 1 diabetes is more likely to develop early in life, hence formerly being called juvenile diabetes. It's typically early onset. Type 2 diabetes, formerly called non-insulin dependent diabetes mellitus, or NIDDM, is 90 to 95% of all known cases. Type 2 diabetes is believed to begin with insulin resistance, where insulin interaction with glucose becomes less efficient, and therefore glucose metabolism is abnormal. More insulin is produced by the pancreas to maintain cellular metabolism, but eventually it can't keep up. Type 2 diabetics have a tendency, type 2 diabetes has a tendency to develop later in life, and patients with type 2 rarely develop ketoacidosis. Latent autoimmune diabetes, or LADA, is a form of type 1 diabetes that is sort of known as 1.5, type 1.5. It is believed that the presence of islet cell antibodies in the blood will eventually destroy the beta cells and insulin production will cease. Patients with LADA, or LADL, are usually not overweight. They have no signs of metabolic syndrome and may or may not have a history of personal or familial autoimmune disease. The diagnosis for latent autoimmune diabetes is based on 3 criteria. 1, onset after age 30. 2, islet cell antibodies circulating in the blood. And 3, insulin is not required sooner than 6 months after diagnosis. Patients can be diagnosed with having type 2 diabetes, but when they are and they're put on oral hypoglycemics, typically they fail. The orals don't take care of it. And insulin is typically started within 1 year of diagnosis. Gestational diabetes occurs with pregnancy, may be treated with diet, oral hypoglycemic agents, or insulin. After delivery, the condition has to be reevaluated because 35 to 60% of women with gestational diabetes go on to be diagnosed with type 2 after delivery, in the years after delivery. The baby also carries an increased risk of type 2 diabetes. An increased risk of type 2. So let's talk about some the etiology of diabetes. So genetic factors. Diabetes runs in families. Metabolic factors can trigger it, emotional or physical stress. It is typically, type 1 is considered a autoimmune disorder, and those where the immune system actually destroys those beta cells. 80% of people with diabetes are obese and have increased caloric intake and are more sedentary. So factors that are associated with type 1 diabetes. Okay, insulin dependent, usually juvenile onset. They typically have a family history or a genetic predisposition to the disease. And type 1 is more common in Caucasian individuals, American Indians, or Alaskan Natives, less common in African Americans, Asians, or Hispanic populations. There will be the presence of islet cell antibodies in the patient's blood. Type 2, non-insulin dependent. Typically, these people can control their problem with diet and oral hypoglycemics. Typically, type 2 diabetics are obese. There is usually a family history of type 2 diabetes or a history of gestational diabetes. Typically, type 2 is impaired glucose metabolism. These people are usually less active, and it is actually more common in African Americans, Hispanic Americans, American Indians, some Asians, and Hawaiian or Pacific Islanders. So clinical categories of diabetes and characteristics. Prediabetes is impaired glucose tolerance and impaired fasting glucose. So for prediabetes, we want our patients to start watching what they're eating, right? So they may have elevated glucose levels when they do a fasting glucose test. So let's talk for a second about hyperglycemia, right? Hyperglycemia is a sign and symptom of diabetes. Hyperglycemia is blood sugar greater than 100, 120. So if your sugar is greater than 100, typically they will say that you have prediabetes. Okay, gestational diabetes, again, with pregnancy, typically once pregnancy is resolved, the diabetes resolves for now, but they are at greater risk for having diabetes type 2 later in life. Symptoms of diabetes. Polydipsia, very thirsty. Frequent urination, polyuria. They're hungry all the time, polyphagia. Rapid weight loss. In type 1, they have a loss of fluid because of that absence of insulin. Typically, they're irritable. They have weakness and fatigue. A lot of times, they'll have nausea and vomiting. Symptoms of type 2 diabetes. They can have the 3 Ps, right? The 3 Ps are the biggies: polydipsia, polyuria, polyphagia. With type 2, though, typically they're going to have excessive weight gain. They're going to have a family history of diabetes. Poor healing of wounds, scratches, abrasions, it takes longer to heal. They might have some blurred vision. They might get itchy. They'll be tired, and they can have some tingling or numbness in the feet. Classic symptoms of diabetes. Always, 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 the 3 Ps are a trigger: polydipsia, polyuria, polyphagia. Then we have fatigue and muscular weakness, weight loss with type 1, weight gain with type 2, more prone to infection with delayed healing, and typically some vascular problems. So screening, starting at 45 years old and about every 3 years after that. When you go into the office for your annual physical, they will do a hemoglobin A1C or a fasting plasma glucose. They can do the 2-hour oral glucose tolerance test, but typically they do that for pregnancy, for gestational diabetes. they will take into account the lab results and patient symptoms. So one thing to remember that there is no cure for diabetes. The goal is to maintain blood glucose levels and lipid levels to prevent complications. So there are some benefits of tight glycemic control, which means keeping the blood sugar within a really narrow range. Typically, it involves multiple blood sugar tests a day and pretty intensive therapy. There are some bad side effects to tight glycemic control, and one of them is hypoglycemia or an insulin reaction. So when the blood sugar falls too low because we have been too aggressive in our treatment, that is a reaction to insulin. But the overall goal of diabetes is to prevent complications, right? Diabetes management. Keep the blood sugar within a normal range, prevent complications. When it comes to older adults, we have to take a few things into account. They are more prone to hypoglycemic episodes, so they are more reactive to that low blood sugar. They can have severe hypoglycemia, which can lead to heart attack or MI, angina, stroke, seizures. So we don't usually recommend tight control for an older patient. Typical A1C for a middle-aged person, we want to decrease to 6.5 or less. That will keep microvascular complications at bay, eye, kidney, nerve problems, right? For an elderly person, an A1C of 8 is typically considered all right. How do we manage diabetes? Diet is the main treatment. Emphasize the foods that are allowed rather than those that are forbidden when we're talking to a patient. So instead of saying, well, you can't ever eat candy again and ice cream again, and you can't ever have soda again because you're diabetic now and no more sweet tea for you, we want to put emphasis on the foods that they actually like, that they can have. So we want to help them figure out what kind of meal plan is going to help them. Things like, we want to make sure that when we're talking about their meal plan, that they are eating correctly. So they can have sweets if they substitute them for carbs and they cut carbs out of their diet when they're having sugar. Proteins should be 15 to 20%. Carbs typically make up almost half of what they eat every day. So typically when we're breaking up their caloric distribution, breakfast is about 20%, lunch was 35%, dinner was 30%, and then they have a snack of 15%. So they have to kind of figure out if they want sweets, what else they have to get rid of. Exercise is important when we're managing diabetes. Muscular activity improves glucose utilization and improves circulation. So it also lowers glucose by burning up the glucose, making insulin receptors on the cells more receptive to the hormone. Improves the use of the available glucose. We do have to remember that when someone with diabetes is exercising, they need to always have something available in case their sugar gets too low. So they have to watch. They need to have some kind of snack. Maybe they need to eat a piece of fruit before even light exercise, if it's done far between meals. But they have to play it by ear, because the more insulin, or the more they exercise, the less insulin they might need. In general, the patient might need to take less insulin and increase their calorie intake with regular exercise. But if they keep a diary of that, it helps them remember what they actually have to have. So the goal of insulin therapy is to closely mimic the person's own natural levels. Insulin has to be by injection. If it's taken orally, it is completely destroyed by gastric juices. So if a patient is doing really tight control, they have control over how much insulin they have based on what they're going to eat. So if they were basing their insulin intake on food, 1 unit of insulin can cover 15 grams of carbs. A lot of people use an insulin pump that gives them a continuous infusion of insulin. It typically helps with improved control. We want to make sure that the patient is taught how to use everything that they need to use, whether that's the glucometer or the insulin, or maybe they have an insulin pen. And we want to make sure that they know when the peak action is, so they don't know if they need to eat anything. But teaching will help improve compliance. We also want to teach them that they should have an emergency plan and supplies for treating low glucose. So if they have signs and symptoms of hypoglycemia, and they are able to swallow, they should take some kind of simple carb or glucose. So that would be like 4 ounces of juice or soda, regular soda, or 8 ounces of milk. You could have 6 or 7 hard candies like Lifesavers, a box of raisins, a tablespoon of honey or sugar, a tube of cake icing, something that's going to get their sugar back up. You can administer 1 milligram of glucagon by injection if they are unable to swallow. So we want to look at some injection sites. One thing we want to remember is if a patient who takes insulin is exercising, when we start to exercise, it's going to help any kind of injection into the muscle distribute faster. So if a person is running, we wouldn't want them to inject their insulin into their thigh, okay? Because they're running, they're going to make it absorb faster and they could have a hypoglycemic episode. We want to teach our patients that the abdomen is the best place for injection because it has the best absorption from their abdomen. And when we talk about rotating sites, we don't want to rotate the actual site. So we wouldn't want to go from the arms to the belly to the leg, or to the back to the leg to the arm. That's not what we're talking about when we're talking about rotating sites. What we're actually trying to tell the patient is to rotate the abdomen. Okay, so maybe the first injection is at 9 a.m. if you were looking at the abdomen like a clock. The first injection's at 9. The next day their injection is at noon, looking at the hands of the clock, so that'd be up on the top. You know, the third day the injection site would be at 3 p.m. as if you're looking at a clock. The fastest absorption site is the belly, the abdomen. The second is the back of the arm, right around the tricep area. Deltoid area. Then the tricep area. The back is actually the slowest. That's what an insulin pump looks like. There are some other options of treatments for type 1 diabetes. If they can find some people to donate some pancreases, they can have an islet cell transplant. About a third of recipients who have this done will develop antibodies and will go back to being insulin dependent. The downfall with this islet cell transplant is that they will have to be on immunosuppressive drugs for the rest of their life. So it's a pretty simple procedure. Cells from the donor's pancreas are injected into the hepatic circulation where they lodge and produce insulin. Not much to it. Nursing management, we're going to monitor the trend of blood glucose, hemoglobin A1C. We're going to monitor for hypoglycemia after insulin injections, and we're going to monitor for signs and symptoms of ketoacidosis. So let's talk a little bit about ketoacidosis. Ketoacidosis is a serious condition caused by incomplete metabolism of fats resulting from an absence or insufficient supply of insulin. When insulin is not present in adequate amounts to meet metabolic needs, the body breaks down protein and fat for energy. This produces an abundance of the byproduct of fat metabolism, which are organic acids called ketones. In an attempt to rid itself of acidosis produced by ketones, the body increases respiratory rate and depth, which is Kussmaul's respirations. Acetone, a ketone body, is excreted in the urine, causing ketonuria. So, if somebody's in ketoacidosis, typically what you're going to find is that their sugar is crazy high, over 400 or 500. They have the 3 Ps going on. They're probably feeling like crud. So their body is not breaking down any of that sugar. That sugar is just staying. But your muscles still need to use something for energy. So it's breaking down proteins, and it's causing those ketones to build up. So we're going to excrete those ketones in urine. And when we smell the breath, it's going to smell like acetone, like nail polish remover kind of. It's a really sweet, fruity smell. So they're blowing it off while they breathe, and they're peeing it out also. So these ketones building up is going to cause metabolic acidosis, dehydration, and electrolyte imbalance. To treat DKA, let's talk about treating DKA. IV fluids are typically what's administered first. And then if there's any kind of electrolyte imbalance, we would try to correct that. Electrolyte imbalance, sorry. As IV fluids are given and insulin is given, potassium can start to get back into the cells and can cause hypokalemia. So we have to watch for that potassium shift because we all know that potassium that is too low or too high can cause lethal cardiac arrhythmias. The goals of treatment of DKA are to return the normal pH to the blood and other body fluids and correct any fluid or electrolyte imbalances. Infection is usually the cause of DKA. However, other causes are things like poor compliance, poor diet and insulin pump failure. The other thing that can happen typically for type 2 diabetics is hyperglycemic hyperosmolar state, HHS, which is their version of high blood glucose levels, typically caused by illness or infection. Greater than 600 milligrams per deciliter are common, in some cases over 1,000. This high sugar causes severe hydration and circulating blood volume depletion secondary to osmotic diuresis. So different from DKA because a small amount of insulin still remains, resulting in the absence of ketones and acidosis. Because ketosis is absent, the GI symptoms don't occur and the patient doesn't seek medical care early in the course of the illness. The patient's mental state may progress from confusion to coma. In contrast to DKA, a patient in HHS may experience generalized or focal seizures. Okay, so there you go. Comparison of hypoglycemia and ketoacidosis. You will find a really nice list of symptoms on page 869. There's a table. Hypoglycemia, low blood sugar. right? You're going to have patients with they might be shaky, hunger, headache, pale, sweating, palpitations, blurred vision, but weakness is huge. They usually get weak. Symptoms can get worse and progress to confusion, loss of consciousness, but individual reactions vary, and at the point at which they will have a reaction varies. Some people can handle a blood sugar of 40 and be okay, and other people have reactions at 80. So you just never know. Some patients can be pretty alert with that low sugar. But if you ever have any patient with an altered level of consciousness, it's important to check that sugar as like the first thing you do. And if that sugar is low, get them some sort of glucose or carb. You have to teach patients how to self-treat hypoglycemia, meaning like carry, suckers with them or whatever. Hard candy, something that they can pop in their mouth. If the person is experiencing seizures or is not alert enough to tolerate oral intake, then we give them glucose via IV or IM. We usually wait 15 minutes, and if we can't, if they're still not awake, then we would give them some more. So that's the difference. The hypoglycemia, they don't have the 3 Ps. They're tired, they're weak, they can have some confusion. With ketoacidosis or severe hyperglycemia, they will have the 3 Ps, and typically they'll have ketones or fruity breath. So when we're teaching our diabetic patients, it's important to teach about foot care. We have circulation issues when we have elevated sugars for too long. So we lose sensation, right? We have neuropathies. When we have neuropathies, we can't feel stuff. So I've taken care of patients who have had gigantic burns on their feet and had no idea. We don't want them cutting their own toenails. We don't want them walking around barefoot. We don't want them walking around in open-toed shoes because we want to protect their feet. Because typically if then they get an infection, they don't heal because of their sugar. So it takes way longer to heal. They can have all sorts of issues. On sick days, when we have a patient with diabetes, we want to make sure that they're checking their sugar often because their sugar can go crazy out of control when they're not feeling good. When they're traveling, we want to make sure that they're taking with them plenty of supplies. We don't want them to get somewhere and realize that they don't have anything to treat hyper or hypoglycemia. And when we're working with an older adult who has diabetes, we want to make sure that we show them all of the little tests that need to be done, how to work the glucometer, how to work your insulin. Maybe they can't drop their insulin because they have arthritis and they need to have an insulin pen. It's our job to make sure that they have what they need to be able to take care of themselves. Let you look at that question. So let's talk about some short-term complications. Short-term complications from diabetes, hyperglycemia. They can have all sorts of cardiovascular problems. They can have kidney problems because of the damage to the vessels. They can have blindness, retinopathy, pretty common. 3 of the most common visual problems are diabetic retinopathy, cataracts, and glaucoma. So retinal damage can cause visual impairment and blindness, and occurs in most people with diabetes within 20 years of diagnosis. So definitely something we have to watch out for. Diabetic neuropathy, approximately 60 to 70% of people with diabetes have mild to severe neuropathy. Those changes in the nervous system cause symptoms like paresthesias, numbness, loss of function. Primarily affects peripheral nerves, can cause sexual impotence in men, constipation, neurogenic bladder, pain or anesthesia, which they just can't feel in the lower extremities. And so we have to make sure that we're taking care of that. Nephropathy, again, due to damage to the blood vessels. The kidneys don't get what they need, so they don't filter as effectively as they should be. Rebound hyperglycemia is something that, also known as the Somogyi effect, typically follows a period of hypoglycemia, often during sleep. So let's say the patient, when hypoglycemia occurs, the patient secretes glucagon, epinephrine, and some hormones to counter effect the low blood sugar. The patient might report having nightmares and night sweats, along with elevated morning glucose levels. The patient increases the insulin dose because of those elevated morning levels and worsens the problem. Typically, the Somogyi effect is diagnosed by checking blood sugars at night and verifying that they're low. So the actual treatment is to lower their insulin. The dawn phenomenon is characterized by elevated blood glucose in the morning, caused by release of growth hormone, glucagon, and epinephrine at night in the body's natural circadian rhythm. These hormones raise the sugar, and the dawn phenomenon is why most people don't tolerate carbs well in the morning. So just some other things to think about there. Here's an example of one type of glucose monitor. There are many other ones out there. Just a nurse teaching a patient. Long-term complications include things like cardiovascular disease, metabolic syndrome, things we just talked about, leading cause of blindness. So remember, macrovascular versus microvascular. Macrovascular occurs over, blood glucose levels elevated over years. Coronary artery disease, peripheral artery disease, stroke. Microvascular is things like neuropathy, nephropathy, retinopathy. Anybody over 70 is at greater risk. And 2/3 from people who have diabetes will die from stroke or heart attack. So as for nursing management, we want to make sure what's going on with their patient. How well are they able to care for themselves? Do they have any signs and symptoms? Do they know what signs and symptoms they're looking for? With hypoglycemia, are they functional or do they black out? Do they know the signs and symptoms? Do they know how to treat it? Do they know the complications that can arise from it? Because there's a lot. We want to make sure that they know if they start feeling hungry, get a headache, they get pale, they get sweaty, have palpitations, then there's probably low sugar and they probably need to eat some candy. It's also something that the community could use more help with. There are educational programs out there. For somebody newly diagnosed with diabetes, it's very overwhelming because it's not only just their diet, but it's medications, it's all sorts of things, it's doctor's visits. So we want to make sure that we get the information out there. There's many hospitals and offices that offer monthly new patient diabetes seminars and classes because there's so many people out there that have it. So, you need to check in, get them checked into a program that can help them teach, because sitting down with somebody for 30 minutes is not going to be enough to let them fully manage their diabetes. That's all for this PowerPoint. Thanks, y'all. Have a good day.